Hi again. I wanted to talk a little bit on something that I have seen a little bit too often. I specialize in sleep also, along with the lung diseases. And so I've seen too many people with obesity, and many of these people are diabetics. And I thought I'll talk today a little bit briefly about the insulin resistance, which many common public knows about it, talks about it. But I think there are a lot of misunderstanding among general public. I compare this understanding of diabetes and the diet and the insulin resistant to the standard chemotherapy that we used to do 10, 20 years ago for the cancers. Since my medical school, I used to feel that doing the regular chemotherapy is on a wrong track. And I feel about the same thing about the diabetes and the diabetic diets that have been prescribed, and how we have new technology and we are doing great according to them. Nowadays we have constant monitoring of sugar through a patch in the skin, and then we also have a insulin pump which gives you a baseline insulin, and then as the sugar goes up it kind of pumps up more insulin. I honestly feel that trying to run after controlling sugar without addressing the basic issue is not on the right track. Again, this is my personal opinion, not necessarily supported by everybody in the diabetic community. But what I can tell you is that the insulin resistance develops because of certain things, which one of which is definitely an obesity. Basically, insulin is, I call it lipogenic. Lipogenic is producing fat. Even though the diabetes is a disease where we talk about carbohydrate and we monitor the sugars and try to control it by giving insulin, all that we are doing is we are converting the glucose into fat, because insulin converts that. So I think in the past and even now, if you look at the American diabetic diet or American society of various subspecialties and their diets, you will notice that average diet should have 1 gram to 1.5 grams of protein per kilogram of body weight, have at least 250 to 350 grams of carbohydrates, and rest from the fats. And the fats are limited because many of these patients have increased triglycerides, increased cholesterol, reduced HDL, increased LDL. And our goal nowadays to control the diabetes and have fats in the blood is to bring down the LDL, which is a bad protein or bile-lipoprotein in the blood, to less than 100 or maybe even less than 80. The goals are great. I think the question is, how do we achieve them? And until we reduce the carbohydrates, we will not do it. I just want to give a basic understanding of carbohydrate metabolism, protein, and fat. In India, there is a guy who has several people that he monitors free of charge. And his basic requirement is that you send him a picture of your report of hemoglobin A1C and a report of insulin level. I can bet you that majority of the endocrinologists or diabetic specialists in this country usually don't even bother to measure the insulin level. His point is that he wants to know that because the insulin resistance is the cause of diabetes, obesity, and in turn hyperlipidemia. And until we control the carbohydrate intake, this will not be controlled. So let me give you an example. If you eat a carbohydrate, protein, or fat, your insulin level will go up. So your insulin level hardly goes up when you eat fat. Fat absorption delays the stomach emptying, so you're full pretty quickly and you tend to eat less, even though each gram of fat is much more calories than protein or carbohydrate. Protein and carbohydrates are 4 calories per gram of carbohydrate, 4 calories per gram of protein. So fat that way is very highly calorigenic. It has more calories, 9 calories. But it does not stimulate insulin production. So when the fats don't promote insulin production, the conversion in the body is very different than when you eat protein or carbohydrate. So for carbohydrate, the curves are very peak. It goes up quickly, goes down quickly. When the sugars start going down because the insulin is secreted, you become hungry and you eat again. So again, there is an up, there is a down. If you take carbohydrates or sweets for that matter, there are two spikes. When you put the thing in the mouth, because you test sugar, the body realizes, A, carbohydrate load is coming, it jumps the insulin, and second load when the carbohydrates start getting absorbed. So we have two spikes of insulin. So this, compared to that, protein has a much lesser curve. So if I would show you the curve which is like this for the carbohydrate, the protein is much smaller and the fat is literally flat. Literally flat. So the curves of insulin secretions are much better for fat than protein than carbohydrates. So if you really want to avoid the insulin resistance, you need to cut the carbohydrate. I know we have been talking about this since Atkins diet, which was no carbohydrate, then Southwick diet, which is again low carbohydrate, no carbohydrate wash-in period, and this and that. So everybody knows about this. But practically, if you would reduce the carbohydrate from 300 grams per day requirement to 125 grams, your insulin resistance will be much better, your weight loss will be much better, and your diabetic control will be much better. Now there is a warning. Because a lot of people take fixed amount of medicines, whether it is a pill form of blood sugar lowering drugs or the insulin long acting that people take shots of it, if you don't take calories and carbohydrate, your sugar will dip. So it is of interest to note that you will need to reduce the dose when you cut the carbohydrate. This cannot be done on your own. You have to talk to your doctor and tell them that you want to try a low carbohydrate diet. Get a prescription for a low carbohydrate diet from your physician where you will have about 125 grams of carbohydrate, where you will have about 70 to 80 grams of protein, and rest of your required calories would come from fats. And distribute this evenly, at least with 2 meals. This distribution and your reduction in the dose of diabetic medication, pill form as well as insulin form, will prevent you having a low blood sugar or going into a diabetic coma, as they call it. So this has to be done with the physician's supervision. It cannot be done without physician supervision. You should not try it alone, because that will not be good. But I'm telling you that until someone reduces the carbohydrate load, insulin resistance will continue. Insulin resistance happens and it's a vicious cycle because insulin deposits fat. Fat causes insulin resistance. People are more fat or obese, insulin resistance gets worse. The blood sugars are worse because insulin is not effective. And so the doctor tends to increase the insulin, which again converts more carbohydrates into fat, which gains the weight, and gaining weight leads to obesity. Obesity leads to insulin resistance. This particular vicious circle that I just mentioned will continue unless you break it by reducing carbohydrate intake. Let me tell you something. Every study that has been done on any diabetic medication, other than metformin does not increase insulin. Any other medicine in the diabetic drug armamentarium which increases insulin will gain weight. You can look at any study, ask any doctor that did people in the study gain weight, and the answer will be yes. So I'm telling you that insulin resistance can be reversed if you control the carbohydrate intake, but it must be done with a physician's assistant. Please do not do it alone. Thank you. I'll probably try to talk about this next time, a little bit more detail. Thank you. Have a nice day. I hope you enjoy this and will subscribe.